I'm Dr. Jonathan Rich, Associate Professor of Medicine at Northwestern University and the Bloom Cardiovascular Institute. We're here in Chicago at our 15th annual Holiday Heart Failure Symposium, where we have leaders from all across the country joining our leaders here at Northwestern to put on this really exciting symposium about heart failure. I am particularly delighted to be here with Dr. Lisa Wilsbacher, a cardiologist at Northwestern and one of my colleagues who is an expert in cardiovascular genetics, to talk a little bit about how genetics play a role in heart failure today. Lisa, we all talk about genetics. We think we sort of know a little bit about genetics. One of the things that I'm pretty sure of, though, is that we can't yet change the genetics that we have, the genetics in our heart, at least not yet. Mm-hmm. So tell us just a little bit about what role genetic testing might actually have today in cardiovascular disease. What scenarios would someone might consider referring a patient to you for genetic testing? Can it influence patient care?
It definitely can. And one of the reasons that we want to make the idea of genetics known to patients with heart failure and for their physicians is that the results that we get with genetic testing, it can change their management. It can have a big impact on their families as well. So one question I often get is, who should I refer? In terms of heart failure, any patient who's been diagnosed with dilated cardiomyopathy at a young age, under age of 50, and you're sure that it's not all because of ischemia, then there's likely going to be a genetic component, and that is the type of person that we would like to at least meet and discuss genetic testing. Any patient with hypertrophic cardiomyopathy, across the board, they should be tested. Those with arrhythmogenic right ventricular cardiomyopathy and left ventricular non-compaction cardiomyopathy. So these are all often based in genetics. There may be a contribution of other factors like ischemia or high blood pressure or diabetes, but we often are worried about having a genetic component. In these patients then, in many cases, we're able to tell them this is why you have this condition, even in the absence of all of these other risk factors. More importantly then, we can tell them these are maybe some of the medicines that you should consider. And most importantly, there are a few mutations and a few genes that if we find this, even if their ejection fraction is not low, their risk of sudden cardiac death is quite high, and we would recommend a defibrillator. So this is one of the key areas where genetic testing can change management in ways that wouldn't have been thought of necessarily. When we find a known mutation in a patient, then we can also have them reach out to their first-degree family members to do cascade genetic testing. We really want to be able to identify their family members who have the mutation and are at risk of developing cardiomyopathy so that they know they need to continue getting lifelong clinical screening, echocardiograms, EKGs, and that the threshold for starting treatment for them is going to be incredibly low so that we can prevent heart failure and the sequelae. On the flip side, any patient in the family that does not have that known mutation can often then be excused from that lifelong testing, saves money, saves time. Many of our patients are quite young with cardiomyopathy and in the process of starting a family or still having kids. And for those patients, knowing what their genetic mutation is, we can do very specific genetic counseling beforehand, and we can even do pre-implantation genetic diagnosis to help these families as well. So, like you said, we can't change the genes yet in the heart, at least not yet, but genetic testing still has a lot of impact in the here and now for these patients and their families.
That's really interesting and very clear. So let me then ask the question a slightly different way. A patient has one of the conditions that you mentioned, a dilated cardiomyopathy, gets referred for genetic testing, and they receive good news. The genetic test comes back negative. Mm-hmm. What does that mean? Are they now in the clear? Does it mean it's not genetic? Where are we now with our understanding of, and how do you counsel not only patients, but teach others, including clinicians like myself, how to interpret a negative genetic test?
This is one of the most important parts of what we do in helping patients understand their genetic cardiomyopathy. A negative result does not mean that it's not genetic. And the number of patients that their initial reaction to having no mutations come up on their genetic testing, many of them say, oh, that's great, I don't have to worry about my kids. And I don't love having to tell them that there is still cause for concern. But the way that we frame it is, we know this is here now. And even though we haven't found the gene yet, we know that we have to follow your kids, and that by completing early screening and regular screening, we'll catch anything that happens early so that we can use these medicines to change it. And those gene panels are rapidly increasing in size. So let's have another conversation again in 5 years. The panel will likely be twice as big. We could always repeat genetic testing and see if we can find the known mutation. And then the last group is those where it's very clear in the family that there are multiple people with cardiomyopathy, and yet we haven't found a gene. We have research programs where we can do whole genome sequencing to identify that family's gene mutation. It takes time, but this is how we're able to both increase the number of genes on the panel and then help those families in particular.
Okay, so very clear again. So I sometimes get reports back from genetic testing, and sometimes it says they have identified a positive mutation. Sometimes it appears the test is quote unquote negative, and your explanation now of the implications of that is very helpful. Can you tell us a little bit about this intermediate result that I sometimes see, this variant of unknown significance, or a VUS? What does that mean exactly? What is a VUS, and how should we interpret that?
Well, what I tell patients even before starting the genetic testing is that genetics results is not a yes or no like most lab tests are. It's a yes, no, or maybe. And the variant of uncertain significance, or VUS, is that maybe answer. It's that gray zone. So this is a variant in their gene. It's a gene that's expressed in the heart, and we know of other known mutations that can cause cardiomyopathy, but their variant is separate, and their variant is one that's either incredibly rare when we look in large population databases, or it's never been reported before at all. It's never been associated with cardiomyopathy, and yet it's still a change in one of these genes that we know other variants can create problems. Overall, we just don't have enough information to say whether that variant had contributed to their cardiomyopathy or not. But we do have some tools that we can use to help us gauge whether that variant is more on the benign end of the spectrum or more on the pathogenic end of the spectrum. And a patient's presentation goes a long way in that. If they're very young and have a very severe phenotype, even if it's a variant of uncertain significance, I'm suspicious. If they have a clear, strong family history, I'm suspicious. And we can then start testing those affected family members. And if every family member who's affected has that same rare variant, now we're making the case this is actually causing the condition.
Sounds significant potentially.
And it can become reclassified as pathogenic. And that's something that we then share with the rest of the community for other families as well.
Great. So I'd like to ask you one more question, if that's okay. At a very basic level, when we refer a patient to clinic for genetic testing, there's genetic counselors, there's the actual genetic testing. Can you just relatively briefly, but so we can understand this better, what exactly happens when they go to genetics clinic, and what is maybe the difference, if you will, between genetic counseling and the important role that that plays, and the actual testing and how those things work together?
Absolutely. The way that we proceed in the cardiovascular clinic at Northwestern is one of two ways. The first is to be referred, and they see our genetic counselor first without seeing the physician. But that counseling session is where the 3-generation pedigree is derived. We ask patients, not just any family members who have heart disease, we ask about every single sibling, child, parent, aunt and uncle on both sides, and then the grandparents on both sides, so that we can better understand how many patients in the family might be affected. From that, then, we talk about those different types of genetic testing results that I explained to you. Patients will come in expecting a yes or no answer, and we want to let them know up front. It's going to be yes, no, or maybe, just to give them that background, and they're ready when they receive their results. And then it's at that visit that the blood draw is actually made and the genetic testing is sent off to be completed. Then the patients return after results are back. It takes anywhere between 3 weeks and 8 weeks these days. And that's where we sit down, do a quick review again of the types of results in that counseling that we first gave, provide them what their results are, what they mean to the patient and to their families, and give them the roadmap of what we're going to do with that information. So that's sort of the post-test genetic counseling. Now sometimes we don't have those as two separate visits for testing first and then they see the physician. Sometimes it's that they see the genetic counselor and the physician at the same day, have the pre-test counseling and the test sent off, and then they come back again 3 to 8 weeks later for those results.
Great. Dr. Wilsbacher, thank you so much for taking the time to speak with me. And to our viewers, I hope you found this information helpful. We're here at this really exciting Heart Failure Symposium in Chicago. For those of you, though, that are unable to join us this time around, please do go to our Northwestern CME website where you can register for future conferences, both for this Heart Failure Conference, but many other wonderful conferences that occur throughout the year. Thank you very much.
Thank you.